Hello everybody. Today we are going to discuss about transpulmonary pressure, which was the question which was asked in DRNB critical care exam in April 2023. So the question was to define transpulmonary pressure, clinical utility and how it is measured. So many critically ill patients needs the invasive mechanical ventilation as a part of their treatment in intensive care unit. Although mechanical ventilation does not support the respiratory muscle and function, inappropriate ventilator setting could lead to the structural lung injury, lead to the ventilator-induced lung injury. Despite the advancement in the diagnosis and management of acute respiratory distress syndrome, the mortality in ARDS ranges from 30 to 45%, with the ventilator-induced lung injury contributing significantly toward it. So ventilator lung injury happens due to volutrauma and barotrauma in the aerated baby lung, along with the atelectotrauma due to cyclic opening and closing of distal airways during tidal ventilation. To limit ventilator-induced lung injury has now become the priority, thus observing the shift towards the use of lung protective mechanical ventilation, which consists of low tidal volume ventilation and avoidance of elevated airway pressure. The concept of driving pressure and transpulmonary pressure has now been increasingly used to understand the respiratory mechanics and to guide the ventilator setting during both uh, controlled and spontaneous assisted mechanical ventilation. So, transpulmonary pressure definition. Transpulmonary pressure is defined as pressure difference across the whole lung, that is between the airway opening and the pleural pressure. It is the net distended pressure applied to the lung, and it is calculated as difference between the alveolar pressure and the pleural pressure. Given that during static condition, the alveolar pressure and the airway opening pressure are the same. In zero state, that is in static condition, the pressure into the airway, that is plateau pressure, P plat at end inspiration, PEEP at end expiration, is assumed to represent alveolar pressure. But the presence of obstructed, closed, and the flooded airway or gas trapping prevents the alveolar pressure from equilibrating with airway pressure. So, esophageal pressure is considered representative of pleural pressure. Now, methods to calculate transpulmonary pressure. The direct measurement assumes that actual values of esophageal pressure reflects the actual value of pleural pressure. So transpulmonary pressure, that is during the end inspiration, is P plat minus esophageal pressure, and during end expiration, the P plat minus esophageal pressure. Now, the elastance derived method assumes that transpulmonary pressure and the pleural pressure is zero at atmospheric pressure, and the elastance should be linear during inflation. So, transpulmonary pressure during end inspiration is airway pressure, that is this end inspiration into elastance upon respiratory system elastance. And the release derived assume that pleural pressure is equal to zero at end expiration and atmospheric pressure. So pleural pressure during the end inspiration is equal to airway pressure minus esophageal pressure minus this esophageal pressure at atmosphere. So the ideal goal of the esophageal manometry when it comes to set the PEEP, it includes the end inspiration transpulmonary pressure should be less than 15 to 20, end expiration should be 0, and transpulmonary driving pressure should be less than 10 to 10 to 12. So esophageal pressure catheter placement and the measure. Esophageal pressure is used as surrogate for the pleural pressure surrounding the lung in upright, healthy individual and can be measured by performing esophageal manometry. So esophageal pressure measurement employs the special balloon filled with air either connected to the standalone catheter or as a part of naso and orogastric tube. It is positioned in the lower third of the esophagus balloon inflated with minimum recorded volume of air and connected to the pressure transducer. Correct balloon positioning in the esophagus is suggested by presence of cardiac oscillations and artifact in the pressure trace. Balloon needs to be optimally air-filled as an underfilled balloon does not properly transmit the esophageal pressure and can underestimate the pressure, where overfilled balloon can overestimate it. The filling volume depends on the dimension and material of the balloon, which is specified by manufacturer. When spontaneous inspiratory efforts are present, Bader test can be used to validate esophageal pressure measurement, wherein simultaneous negative deflection of airway and esophageal pressure during end expiratory occlusion maneuver are compared. The change in airway and esophageal pressure during occluded inspiration should almost be the same as lung volume does not change. So, so does transpulmonary pressure. So esophageal pressure is considered to be reliable when the ratio of esophageal pressure and the airway pressure rise between zero point 0.8 to 1.2. Else catheter position and the balloon volume should be reached. In patient without spontaneous respiratory effort, external manual chest compression should be applied during expiratory pause and the comparison should be made between simultaneous positive deflection of air and esophageal pressure, and this is the positive pressure occlusion test. Now, confounding factor in pleural pressure measurement using esophageal pressure. Elastic recoil of the balloon, esophageal muscle tone, elastic recoil of the esophageal wall, vertical hydrostatic gradient of pleural pressure in both upright and supine position, cephalad movement of the diaphragm and the weight of mediastinum in supine position, transmission of intra-abdominal pressure in homogeneous lung disease, presence of the pleural effusion, pulmonary and chest wall edema. Now, rationale for transpulmonary pressure measurement. It allows to differentiate the contribution of the lung and the chest wall towards the airway pressure. So, airway pressure equals to the total of the pressure delivered to distend the lung and chest. When the flow is present, pressure that is needed to overcome resistive forces. So, airway pressure is the poor surrogate of the lung stress. On the other hand, the pleural pressure is the true distending pressure of the lung, independent from the effect of chest wall and the abdomen, and thus allows the differentiating lung and the chest wall components. This is the diagram shows the end expiratory occlusion maneuver. Now, utility of the transpulmonary pressure and esophageal pressure in the mechanical ventilation. So, first use is to adjust the PEEP to counter the baseline elevated pleural pressure and the consequent negative pleural pressure and the lung collapse found patient with the and consequent negative transpulmonary pressure and the lung collapse found in the patient with the obesity, intra-abdominal hypertension, abdominal distension, pulmonary edema, pleural effusion, chest wall edema, and ARDS. So it is suggested to set PEEP to maintain the end expiratory transpulmonary pressure between 0 and 10. Lung collapse can cause closure of the air, leads to the decreased aeration, worsening respiratory mechanics, decreased lung size, participating in the gas exchange. So elevated esophageal pressure can be measured as surrogate for pleural pressure, and PEEP can be adjusted above this closing pressure to positive pleural pressure to prevent collapse at the derecruit. In single-center randomized controlled trial by the Talmor et al., the EVENT trial enrolling 61 patients, they compared standard of care lung protective ventilation using the NIH ARDS network PEEP FiO2 table with strategy of the PEEP titration to achieve positive transpulmonary pressure. That is, PEEP was titrated to end expiratory transpulmonary pressure of 0 to 10 while maintaining end inspiratory transpulmonary pressure less than 25. The latter, when compared to ARDS net ventilation strategy, was found to be associated with significantly higher level of the PEEP, better oxygenation and respiratory system compliance, shorter duration of mechanical ventilation, and trend towards improved adjusted survival. In validation study by Yoshida et al. On pigs and the human cadaver, published in 2018, they concluded expiratory transpulmonary pressure derived from the esophageal pressure reflects the transpulmonary pressure in dependent to middle lung, which is the most prone to atelectasis and atelectothromb. In another multicenter randomized controlled trial enrolling 200 patients by Belter et al. Published in 2019, the IPVENT-2 trial, PIP titration guided by esophageal pressure was compared to the empirical high PIP FiO2 in moderate to severe ARDS. So esophageal guided PIP titration result in no significant difference in composite outcome that incorporate death and days free from the mechanical ventilation through day. So they concluded that these findings do not support esophageal pressure guided PEEP titration in ARDS. Now to avoid, now the next use is to avoid lung distension and titrate the recruitment manner. To limit the ventilator induced lung injury due to local overdistension in aerated baby lung, that is ventilated non-dependent lung region, it has been suggested that transpulmonary driving pressure to be kept less than 10 to 12 to prevent lung injury. And it is suggested to keep end inspiratory transpulmonary pressure below 20 to 25 to prevent ventilator-induced lung injury due to overdistension. In the validation study by Yoshida, they concluded that end inspiratory transpulmonary pressure estimated from elastance ratio reflected local distending pressure in the non-dependent babylon. In report by Grasso et al. In small cohort of 14 patients with severe H1N1 associated ARDS referred to extracorporeal membrane oxygenation, they increased PEEP until the end inspiratory pleural pressure was 25 using elastance method, which led to improvement in oxygenation index in 50% of patients, allowing them to be managed with conventional ventilation and avoiding ECMO support. To guide spontaneously breathing activity. The protective effect of spontaneous breathing by improved gas exchange and oxygenation happen by lowering lowering the pleural pressure and consequent increasing transpulmonary pressure. But this protective effect has been noted only in mild ARDS patients. In severe ARDS with increased spontaneous demand, this may prove deleterious. The same has been suggested for beneficial effect of neuromuscular blockage in patients with severe ARDS in different studies by Papazian et al. And Yoshida et al. In severe ARDS patients, the vigorous spontaneous effort may lead to injurious high transpulmonary pressure, causing patient self-inflicted lung injury, increasing thickness of diaphragm that is associated with prolonged ventilation, and increased chance of lung edema due to increase in the transmural vascular pressure. So, to protect lung from the PCL and diaphragm from injury in severe ARDS patients, it is critical to monitor spontaneous breathing activity, which can be detected by negative deflection of esophageal pressure and end inspiratory pleural pressure can be calculated and maintained in safe range, that is below 20 to 25 centimeter of water. To estimate respiratory muscle effort and work of breathing. In critically ill patient with hemodynamic instability, it becomes important to optimize oxygen delivery to the vital organ. Increased work of breathing due to respiratory muscle effort may warrant adequate sedation and ventilation. The esophageal pressure time product has got good correlation with energy expenditure and oxygen consumption of respiratory muscle and correspond to area under pressure generated by respiratory muscle curve over inspiratory time. So work of breathing corresponds to integral of product of pressure generated by respiratory muscle and generated volume. Now monitoring of the patient ventilator asynchrony. It is not unusual to witness asynchrony during assist control and pressure support modes of ventilation and can be defined as a time mismatch between patient's effort and ventilator breath duration. It has been found to be associated with prolonged ventilator days and high mortality when asynchrony index is more than 10%. Different class of asynchrony include trigger and cyclic asynchrony and flow delivered mismatch. In effective effort, double triggering and auto triggering are various types of trigger asynchrony. This justifies the use of signal like electrical activity of diaphragm or esophageal pressure to detect asynchrony. Esophageal pressure swings can be compared with those of airway pressure in the flow time graph and appropriate intervention in ventilator setting done to minimize asynchrony. Now esophageal pressure monitoring to assist weaning from the ventilator. With esophageal catheter in situ, interpreting the esophageal pressure swing in case of difficult weaning. Worsening of mechanics as a cause of weaning failure can be determined and necessarily action taken accordingly. For example, instituting bronchodilator, vasodilator, and diuretic in case of increased airway resistance or bronchial and cardiogenic pulmonary edema respectively. Thank you guys.